I now recognize Ms. Sewell for 5 minutes.
Thank you, Mr. Chairman. I want to thank all of you for being here today. For me, I represent both an urban area, Birmingham, Alabama, underserved, and a huge swath is rural. And picking up where my chairman just left, Chairman Smith just left, prior authorization is the #1 complaint I hear about. The #1, and the delays in payment have exacerbated an already financially insecure hospitals. I represent Alabama that did not expand Medicaid. My rural hospitals are teetering on the edge, and when I hear time and time again about prior authorization, it almost, I mean, it's mind-boggling that the denial rate is so high. And I know, Ms. Maroney, you actually said that your denial rate was just 2%. So can you enlighten me as to how you were able to get your denial rates lower?
Thank you so much for that question, and we take pride in that. You know, there are a lot of referrals that people go through that should be auto-approved. There should be no hold time. And approximately, probably about 95 to 97% of prior auths that come through the system are automatically approved at alignment. The other thing is which I heard a little bit earlier about the prevention and component, and which is critical. We have a belief system through our Jumpstart assessment program for every new enrollee that enrolls into the program. It is our goal to see them immediately within the first 90 days or 120 days to make sure that there's no continuity of care issues.
So it sounds like you are trying to on the front end, prevent chronic diseases, and in doing so, you're saving money and obviously saving people's lives as well.
Absolutely.
One of my hospitals, DCH Regional Medical Center in Tuscaloosa, has consistently experienced an increased disparity in the performance of MA plans compared to traditional Medicare, stemming from pre-authorizations, inconsistent payer communication, unpredictable claim denials. The average number of days it takes to receive reimbursement for services from traditional Medicare for DCH, this particular hospital, is about 18 days. So traditional Medicare, 18 days. But for MA plans, the same hospital has to wait anywhere from 21 to 66 days for a pre-authorization. Now, I know the Biden administration did much needed reform on pre-authorization, but it didn't go, in my opinion, far enough. And so the leadership of DCH wrote to me explaining an instance where a team member spent nearly an hour trying to obtain a prior authorization for an inpatient admission, despite successfully obtaining the approval. The claim was later denied for, quote, no authorization on file, end quote. This led to a full appeal, which included resubmitting data and follow-up, multiple follow-ups, all to eventually get the original authorization honored. We cannot afford to have this kind of insanity, for lack of a better word, and think that we can actually fix our very frail healthcare system. And so, Dr. Basil, I wanted to know from you, how can, and let me just back up. And now I hear that AI may be replacing live people on the other end of these pre-authorizations, only complicating matters. So what assurances can I give to my constituents, especially in rural parts of my district, that MA reform is likely to happen and continue to happen, and that it won't restrict access?
Right, so your data actually is very similar to what we see. We see about 20 days on average for accounts receivable for traditional Medicare and considerably longer for MA, and so that is consistent with our experience with the MA plans as well. You mentioned AI, and so that is something that AI could be a good thing, because if it helps increase the speed to where you can get a prior authorization approved because it automatically, kind of gold cards you or something like that, AI could be a very good thing.
Yeah, it depends upon what algorithms you feed into it. So if your first instinct as an insurer is to deny, then an AI wouldn't necessarily benefit that.
Right.
And I know I'm running out of time, and I did want to ask Mr. Fiedler, sorry. If you could also expound upon what you were saying about rural hospitals and MA. I know, yeah. In particular, you were the large number of rates of denials for MA.
So, I mean, certainly to the extent that hospitals are experiencing higher denial rates in MA, that has implications for their bottom lines. You know, some hospitals are going to be able to absorb that, some hospitals are not, and it's going to sort of depend on, well, you know, what's the financial condition at baseline.
Yeah, thank you, Mr. Chairman. I'm sorry to extend my time, but I think that it's really important that we get to the 20% more costs for medical Medicare Advantage over traditional Medicare. That's $83 billion worth of waste.
Let's get together on that.
So let's work on that. Thank you, sir.